Hello, my name's Tom Dewar. I'm Head of Information at St George's Healthcare NHS Trust. I'm here today to talk to you about how we use Tableau and how we use it to transform healthcare data into insight, is my title, and that's what I hope we do. But before I get into the nitty-gritty of all that, I want to do a little bit of backstory, because I think the NHS or healthcare in the UK has got a bit of a claim on some of the early days of data visualizations. I want to take you back to the mid-1800s, so contrary to what my 9-year-old son would say, I wasn't alive then, but I want to take you to Florence Nightingale, so I'm assuming that most of you have at least heard of her. Now, you probably know her as Florence Nightingale as a nursing legend, which she was, but she should probably also be remembered as a statistician and a data visualization legend as well, although I doubt data visualization was a term widely used at the time. As a slight aside, I quite like their verbose titles they used at the time. The title on the screen there is title of a book that she wrote, which I always like the matter-of-factness about those. These days it would be called something boring like deaths and how to prevent them, but I digress. So she realized, Florence Nightingale realized that data mattered, that there was not a lot collected, not a lot of statistics collected in those days, and she was involved in the Crimean War as a nurse. Went over there with 38 nurses, I think, to set up a hospital, and this was in mid-1850s or thereabouts. And she, obviously saw a lot of horrific things, but there was very little information was collected and almost none used to further the actual healthcare of the soldiers out there. And on her return, she did a lot of work with a man called William Farr. Now, William was a sort of leading statistician of the day as well, and they were analysing mortality rates and the causes of death of English soldiers at war and at home. And they discovered that your typical English squaddy of the day was subject to something like a 60% mortality rate. Now, that's pretty horrific. Maybe not surprising. I wasn't very surprised to hear that, I have to say, but I assumed that was mostly on the battlefield, but it wasn't. Most of that was not from the battlefield. It was from disease and unsanitary living conditions that they had to put up with. And she, as well as getting that information, they realized that it wasn't enough just to know that. You had to share it, you had to convince others that mattered and that they could do something about it. Now, in the 1800s, newspapers looked a little bit like this, not big on graphics, I have to say, to be honest as well. And compared to these days where we have things like this, which I'm not entirely sure is progress, but it's definitely more graphical. And as I said, Florence Nightingale, William Farr, they realized that the presentation of that data was really important. It wasn't good enough just to do tables and numbers. They wanted to persuade people and to have that power to persuade them to do something differently. So they produced graphics look a little bit like this. This is an example from them. Often referred to as a coxcomb diagram, although I think it's more accurately called a polar area graph. And I'm just going to take you through it briefly. And on the right-hand side, you have the year represented as that circle, with each of the sort of 12 spokes is a month. You kind of got winter at the bottom and summer at the top. I'm sure the writing's probably a little bit small to see, but the areas there, it's a bit like an area line chart that sort of wraps around in a circle, and the areas represent the numbers of death, and with different shadings, different colours to indicate the different causes or groups of causes. Draw your attention to that small red part there. That's what I would normally consider to be the main cause of death in a battle. It's deaths from wounds and such like. But then there's this area here, this slightly larger green area. That's deaths from disease, which is absolutely dwarfs the deaths on the battlefield, as you can see. So now, I'm sure in this day and age we might pick holes in data presentation, and we might do it differently. You can see she obviously didn't have a copy of Tableau to work with, but it's pretty good, and I think you'd agree it definitely has the impact. And it was using charts like this that Nightingale and Farr persuaded the army of the day to start collecting information more systematically in the first instance, but also to change their practices and to really increase the sanitary conditions in hospitals, not just in military hospitals, but in civilian hospitals as well. No doubt saved a lot of lives. So Florence Nightingale then, legendary nurse, statistical and data visual pioneer as well. And that's a long way to give me my tenuous link, but real link, I think, into my own work and or the work that we've been doing at St George's. So at St George's, where we're working with statistical and visual work, visual data, and really trying to carry on that tradition because like Florence Nightingale and William Farr, I'm sure, we really want to take the information that we garner from the delivery of healthcare and for treating patients and making them better, to actually improving that healthcare. It's not good enough just to make people better. We want to make the business of making people better. So my introduction to Tableau, I wanted to give you a little anecdote really which is actually from a previous hospital I worked in, so I'm afraid I haven't got any screenshots for this, but it was really my sort of personal tipping point into the potential power of this as a product. So I was summoned or called along with a general manager from that hospital, a manager who was responsible for accident emergency, to go and meet another analyst who worked for the then Strategic Health Authority in London, who was very pleased with himself because he built a very comprehensive data set and analysis tool in Excel of A&E activity from all the trusts in our area. And so we went along, and it was slightly odd set up as there were just three of us in this large boardroom, but he projected his 63 megabytes spreadsheet up on the screen. And I confess I'd done a little bit of prep. I had my trial copy of Tableau at that time, and I was looking for something to really test it out on. And I'd loaded up, because I had a vague idea of what he was going to do. I'd loaded up our own trust's A&E data onto my laptop, all encrypted, so it was nice and secure. And as this analyst presented his work, he was basically showing different cuts of our data. The number of people who attend A&E split by hour of day, month of year, etc. Some performance metrics around it. And as he was doing so, as he was projecting that up on the screen, I was sat directly beside my general manager, and she, whilst he was explaining to her whatever diagram he put up on, or whatever chart he displayed on screen, I would sort of busy myself away for 30 seconds and reproduce it in Tableau, and I was able to just tilt the screen towards her and go, well, that's what it looks like when on our data and when we do it in house. And that for me was pretty monumental. The ability to build something that quickly. I mean, this guy with the spreadsheet, he'd been, it was probably a good piece of work, but he'd spent weeks putting it all together, and admittedly it wasn't just our trust, but to be able to reproduce that in such a short period of time was really powerful. And to be able to, at that point, I realised I could sit with a decision maker and I could do analysis with them and directly in front of them without having to, get into this stop-start of asking a series of questions. I'll go away and come back in a couple of weeks, and going through these sort of series of weekly or monthly meetings where I'll never get anything done. So that was my personal tipping point anyway. But when I got to St George's, I joined St George's in 2012, so not all that long ago. The organisation, St George's, had a kind of an unplanned, evolved collection of different business intelligence type installations sort of scattered around the place. We had a bit of business objects over here. We had lots of Microsoft stuff around. We had a few random ClickView licenses, which had come bundled with a theatre system we bought, for example, and probably a few others that I've forgotten as well. And I didn't really want my team, so I'm responsible for an analytical team at the Trust, supporting management information. I didn't want my team having to support, an ever-growing and random ecosystem of different products. Didn't want to be using such a wide variety of products, really, if there was one or two that really did the job really well. So I persuaded my boss, who joined at the same time as I did, helpfully, that it would be a good idea to do a rapid appraisal of the different options that we have out there, and to put our corporate might, as it were, put our money behind the one or two which really covered what we needed to do, and to really have a sort of strategic solution to this general problem. So we looked at four different shortlisted products. Those being Tableau, ClickView, Business Objects, and the sort of Microsoft suite of products. And we had we tried to be analytical about it, as you might hope, and we had two particular sorts of use case, or case use of whatever the term is, in mind. The first thing firstly, we were after a tool which we analysts could use to do, the quick bits of quick and dirty analysis. There doesn't really seem to be much time to do any other sort in NHS, I have to say, but something we could do, so that quick analysis, or just drop some data in, squeeze it for a bit of insight, perhaps turn it into a neat chart for presentation at short notice, those sorts of things. Sorts of things we would otherwise be using Excel for, but just better for the job, frankly. And secondly, we're after a tool that would more of a sort of dashboard type tool, so something that we could create dynamic reports that our users could sort of self-serve on. They could go to, they could enter a few parameters, get the information they needed in a form that they could use and act on quickly. So those were our two sort of dimensions, if you like. And we did do a sort of scoring thing, and what I'm putting up here in front of you isn't sort of, doesn't have a scale on it. This is more a conceptual diagram of where we ended up. So roughly speaking, we had Tableau and ClickView. There was clear water between those two products and the others that we looked at. And between those, it was pretty close, I have to say, on the sort of dashboard side. And one or two people in my finance department, for example, actually preferred some of the ClickView, the flexibility, I suppose, or the number of different things it could do. But the thing that really tipped it for us, and on both, but definitely on the analytical side, was that rapid, the rapidity with which you could develop, which I gave you an example of a few moments ago. So the ability to produce something quickly and to a high quality standard was really quite definitive for us, I think. And I mean, it's not just a point of convenience, really. I am obviously a selfish analyst, and I like to use tools that are pleasant to use and quick to use. But for us, it's, the reality of the office that I work in, something being a tool that is quick to use in this case, it's not the difference between it's nice or it's not nice. It's the difference between doing or not doing. If I've got 10 minutes to put something together because the chief exec is in a hurry and needs something to illustrate the trend in any attendances, if I can't produce it that quickly, it's not going to get done. You produce the content that you can in the time available. That's very much the world in which I live in. And being able to produce high quality content in such a short period of time is really, really important. So I'm going to talk a little bit about the general setups. This is more sort of techie side of how we're sort of structured. Happy to take questions on this at the end and stuff as well. I'll come back to this. So we have we started off with a few desktop licenses. We very rapidly expanded and bought an 8-core enterprise server license. So that gives us unlimited users on the Tableau server, but limits the the server hardware, as it were. But there's never been a problem. So I suppose there's some theoretical limit that we've never hit. It's beyond my personal comprehension, probably, around how many users we can have. But effectively, that does us plenty fine. We have a pretty new data warehouse as well, through which we try and pass all, but we don't pass all. We pass a lot of our sort of systems information. So we have a lot of different administration systems, which are the main sources of our data. We have, the biggest one is based on an Oracle platform. Is our patient administration system, holds all our key information, but we also have a lot of peripheral systems, radiology, maternity, different sorts of critical care, a whole mix of different things. The general IT trend is to start to integrate those and reduce the number of those, but that's a different conversation. We also, unfortunately, I suppose, have this legacy and this history of this sort of amorphous mass of different spreadsheets and access databases that are used. Often I have to say in my own department. Usually they've been produced on something had to be done on a hurry basis, and then suddenly the thing became a regular thing, and no one's had time to do anything smarter with it. But there's a lot of spreadsheets and stuff, information we get through spreadsheets out and about in the business, which with all the pitfalls of that entails too. And some of those, a few of those are fed into the data warehouse. More often we'll try and eliminate them and incorporate them in a better way. And a few we will feed through to Tableau server as well. So my team, as represented at the bottom there, the information team, it's about 20 of us, and we are, as I said, the sort of management information function for an organisation of about 8,000 people. And our customers are corporate and clinical, and we don't do enough. We'd like to do more analysis, and we do a lot of answering questions. Basically, we do a lot of answering some of them pretty basic questions. How much activity have I done? What's my performance? All of that sort of stuff. And we have in the organisation now, I think we've got 20 or 25 desktop licenses. So the majority of those are in the information team, in my team. But we do have, I think, 3 or 4 now outside of our team. So we've decided to go for a model where I will handle or my team will handle all the sort of licensing aspects as well. And so, but if we have particularly data literate, which we do have a small number and growing number, really data savvy general managers or other people in amongst our customer base who would benefit from being able to use the sort of full, desktop package, then they can have that. They have to pay for it out of their budget, but I will set up. I'll organise it up. So I'll place the order and cross-charge them for it. We will support them getting connected. As I said, we have probably, I think, 3 or 4 like that at the minute, but that'll trickle up. So that's our basic current setup. What's been the most interesting part? I'm not sure. I was going to show you some examples. Apologies, I'm not going to show you a live demo. I've got a lot of our stuff. It's got quite sensitive, patient details and etc. behind it. But so I'm going to show you screenshots, but which I'm afraid obviously misses off the all the interactive good stuff. But I'll talk you through what we've got, show you some examples, and you can ask questions later as well if you like. So average length of stay. This is one of the first visualizations I put together once we had the product installed. This is so as a hospital we're quite services are quite hot. We like to measure average length of stay. It's an efficiency measure for those of you not in the industry, I suppose. But it's a little bit careful because obviously we're not in the business of kicking people out of hospital when they're still ill, but all other things being equal, there are always people in hospital, and our hospital is not unique in this case. There are always people in hospital who don't need to be in hospital, and that could be for a variety of reasons. But as we progress and crack that problem, the one impact of that is that the average length of stay reduces, and so measuring average length of stay is a way to get a handle on that. But if you're looking at it in a short-term way, it can be quite skewed. So this chart is this graphic is showing sort of volume is the bars, and the lines there are the average length of stay. So that's saying we have what 5. This is for one particular division, so it's not all of our activity. But that's something the user can select on the right-hand side there. They can select basically different organizational levels. They pick a particular specialty. So say you're the okay, I want to take you through some examples now now apologies, I'm not going to show you a live interaction of our systems. We've got quite a lot of sensitive patient detail, etc. behind, and I'm often in the habit of configuring it so that will pop up on hoverovers in some of these examples. So I've resorted to screenshots, I'm afraid, but hopefully you will bear with me. The first I'm going to show you is one of the first views that we did, and this is of average length of stay. Now, for those of you not in the hospital sector, this probably won't mean an awful lot to you, but it's kind of used as a measure of efficiency in some ways. Now, you have to be a little bit careful. We're not in the business of kicking people out of hospital too early when they're still ill, but our hospital, like all hospitals in this country, have patients who are medically fit to be discharged, but for other medical reasons have not yet been discharged. And those patients occupying a bed that we could be using for another patient. So it's kind of a measure of efficiency. This view, where I'm showing you the interactive version, you would be able to select on the right-hand side the different organizational hierarchy levels. So if you are the manager for general surgery, for example, you could select that and see what your performance was like. And this is just showing over time, grey bars is volume, and the blue lines there are the average length of stay. So not an awful lot happening on that one. But and at the bottom, again, if this was the interactive version, the user could highlight a particular month, say a particular month where it looked like it spiked and gone up. And that length of stay distribution, which is sort of a dot chart of some sort, gives you an idea of whether you've got any outliers. You might faintly see there are a couple of big outliers, because average length of stay is a mean, so it is vulnerable to the occasional patient who stays a very, very long time. And we do have a few patients who stay a very, very long time. So the next one I want to show you is slightly more recent. This is at a request from a clinical director, actually, to produce something that allowed him to get a handle on the volumes and who was requesting radiological tests. So these are things like CT scans, MRI scans, X-rays, ultrasounds, etc. And this was the consequence. Now this is sort of version 1. We already have a commission for version 2 with a few changes, but this again shows volumes over time, allows the user to select the different types of exam. I'm using terms that are familiar to my customer here, so exam wouldn't be my first choice, but that's the term they use. And you're able to see the sort of top requesting specialties there on the left-hand side. I've redacted names, but on the right-hand side, those are the top requesting consultants. And there's a bit of dynamicism in this, in the sense that a user can click on a specialty and that will filter the consultants, for example. So third of 4 examples I'm going to show you. Third example is one that's basically just showing activity versus plan. Now, the hospital activity is managed on a sort of contractual basis with clinical commissioning groups. They are our commissioners. And we effectively agree a plan of activity, that is how many how many outpatient attendance we expect to see, how many elective cases we expect to see, etc. And theoretically, they pay us for whatever we do, but we are monitored against contract, and it is generally useful to see whether we are, busier than we thought in some specialties, or not as busy in other specialties, and what the financial impact of that is. And this is an attempt to get a quick visual handle on that. And in particular, this was designed to show people in-month performance. So before this view, people, general managers, clinical leads, would only get information on how they were doing, how they were doing versus their plans. Several weeks after the end of a month, they would get the monthly information. This is showing them not real time, but in-month data. The data behind it is actually updated daily, but it's plotting it as weekly data points. So those blue bars there, for example, are the number of elective admissions by week versus the red line there, which is plan. So you can see it is pretty much tracking plan. That the dips correspond to bank holiday weeks. Your scatter chart in the middle there, that's just showing plan versus percent variance from plan. So it gives you a quick visual, and the size, I should say, is proportionate to the value of that. So it gives you a quick visual sense of high volume, low volume specialties, whether they're above or below expected levels. And the last example I'm going to show you is the most recent, and I think it's possibly the most exciting. Is probably not quite the right word given the topic, but I support one of the deputy medical directors who runs a mortality monitoring group in the hospital. So the hospitals have very, very strong clinical audit processes around really examining any issues that are reported, and in this case they investigate not all deaths, but a large proportion of deaths, not because they think they're suspicious, but just to stay on top of them. So, for example, any elective patient, any patient who wasn't admitted in emergency who died would be investigated as a matter of course. This was a tool to try and help that audit process. So it's aimed at a smaller cohort of people, clinical auditors, and a few of the senior clinicians, and potentially individual consultants in the future. And this allows, so that sort of heat map on the left-hand side, that's the number of people who died by day. Now, don't be alarmed, those numbers are small. I can promise you, in the context of the number of people we see in our hospital. And we even have the odd day where nobody dies. But this allows my deputy medical director to be able to select and really drill into that. So on the left-hand side, you've got that heat map which shows the numbers. If you were to click on one or more, you can multi-select on that. You will get a filtered view in the top middle of the screen there of the individual patients who died, with some very basic information, just basically a hospital identifier, which I've redacted down the middle there, and quick gender and age split. And it's faded, I'm afraid, because I selected something, but the hour of death, you get a visual display of what time of day the patient died. Was it in particular, was it shaded area, which is nighttime or daytime, and how long they've been in hospital before they died. And if you click on one of those, which I have and did to produce this particular example, it brings up the like a Gantt style chart at the bottom. The black lines there are redactions, not part of the visual display, I should say, which shows you where they stayed. In this case, they were all on the same ward. So the colour of those bars is the ward that they were on, which is of interest, and the primary diagnosis and the primary procedure code that's been recorded. Now, so this is a quick way for, as I said, clinical auditors and associated staff to quickly hone in and look at some, patients who have died, and we've even got as far as building in a dynamic link such that somebody can click through the right-click menu, hover over menu in Tableau. They get a dynamically generated hyperlink, which if they click will take them to that patient's electronic record. So the hospital, in a completely independent initiative, has started scanning its paper notes and records. That's a mammoth job in itself, but this link will take you to that patient's scanned record, basically, or will do once they actually start scanning those records, which is imminent. So the link works, obviously not on a screenshot, but I can tell you that the clinical staff involved in this are very excited about the time it's going to save them and their ability to really process things much faster and complete those sort of investigations much quicker. So the challenges, I just want to say a bit about some of the challenges we've faced in use of this product. And these aren't all challenges with the product itself, they're just part of the landscape. So we have big issues with data quality. We're not like these web companies, etc., where it's just collecting click data and it's all automatically collected. I'm sure it's dead easy, he says. No, almost all of the information that we are dealing with has been entered by a human being at some point. And because it's been entered by a human being, that human being is probably pretty busy with some other things. It probably isn't their permanent job to enter data. They may be nurses, they may be ward staff, they may be receptionists, they may be whatever. And so data quality can be a big problem. And there's an acronym I won't go over, but if you don't put good stuff in, you don't get good stuff out. So it's something we as analysts, I think, have to really be aware of. And Tableau doesn't sort it out for you. It does help in that there are visualizations we can produce that will help us diagnose data quality issues, and we do some of that, and we will do more. But it's something we just have to be permanently aware of, and it's a big job. The second one is upgrades, basically. Every time we feel like we get on top of things, somebody decides they need to upgrade some system somewhere. I'm not talking about Tableau upgrades. We've only done one or two of those, and they've gone pretty faultlessly. I'm talking about updates to our main administrative systems, if you remember that diagram, stuff on the left-hand side, or or the feeds into our warehouse from those systems. We've had a few changes which are not supposed to have an impact, which inevitably always do, and hence the cartoon on the right side pretty much sums up my usual end opinion of an upgrade about 24 hours after it's happened, which is, don't do that again. Do we really need that functionality? I don't think so. And this last one is possibly the most challenging of all, really, which is to try and break out of the request response cycle or circle. So that's about my department. The MO of the organisation is my department are the go-to people because they're helpful. They're knowledgeable guys. They go to people for questions about any question about data. But a lot of those questions are really basic. How many patients did I have attending last week, last month, last year? Real basic stuff that does not need a highly paid analyst to really be producing that. But we are at the minute for various reasons. And to break that down, I will come on to that breaking that cycle and getting us onto a front foot where my team are adding the value that they can add through analysis and interpretation and advice, rather than literally the ferrying of data from one place to another. That's a big goal for me. So in the future, this is starting from the diagram I showed you before, but we want to do a number of things. We want to get rid of access pretty much as a tool. There's really no reason for us to be using it at all now, and dramatically cut down the amount of spreadsheet collection of data and manipulation of data. We want to eliminate it. It actually is a prototyping, as a tool for sort of prototyping things. It's pretty good. Excel, I think, is very good for some other things, but not the way it's used here. So we'll trim down but not eliminate use of Excel. I'm sure we will expand both the number of different feeds into our warehouse and the content within those feeds will extend. So we'll have feeds from new systems, from different administration systems, from HR systems we haven't yet got a feed in from, but working on financial systems, etc. We will have expanded the use from our customers. We really want them to draw down and to be able to pull down that information that they need. And that arrow coming down from into clinical and corporate, that big arrow, that's what we're trying to get to. That's customers, instead of having a thought, asking a question, hoping they get an answer, getting an answer, having a thought, go to a web link, type in a couple of parameters themselves, get the answer straight away. That's where we're going to. And that will reduce that sort of ad hoc request type burden on my team, thereby freeing up the time. So the theory goes for us to spend much more time really putting that layer of intelligence on top. And I would expect we have, I think, 20 or 25 licenses, desktop licenses now. I'm certain we will extend that. I don't think we'll get to hundreds or thousands, but we'll I ordered another 5 pretty recently, and probably going to order another 5 not too distant future. Ben Beers might prick up if he's in the room at that. But so that's where we're going on the sort of technical front. So the priorities for us from here, these 3 really. So I've touched on a little bit of this already, but priorities for us as a hospital in using Tableau and using data more generally are standardization of data sets is really key. So we're only able to really tap into that rapidity of development, that real benefit that was one of the key reasons we bought Tableau in the first place. We can only really exploit that fully if we really got our data in good shape beforehand. Now, data quality is an issue, but it's not a stopping issue there. But it's about having, well, this audience probably knows, but it's about having a good structure of your data, knowing something about the sorts of questions you're going to be asked, more tells you something about how you structure it. And we have a lot of work going on in my sort of sub-team of mine, sort of technical side, is about producing those sort of particular starting points from Tableau's point of view, but particular views of data in a particular way. And we will get better at documenting and change controlling those as we set them up, and we will also be extending the number of them that we have. Again, happy to talk questions, or if anyone from the NHS is around, grab me afterwards, and happy to talk for a long time about those sorts of things. Ease of access, again, big reason for getting Tableau in the first point was it's easy to use, both as a developer and as a sort of customer, as it were, a user. And we want to extend that further. We will need to do a bit more documentation, I suppose, frequently asked questions, but also how-to guides. Haven't done yet, but I'm considering recording really short sort of screen recordings, sort of 20, 30-second screen recordings, just showing you how to export to PDF, print, drill down to patient level, but using sort of bespoke, using our own reports as examples, so that's really familiar. And that's really to tap into. I mean, there's some really good stuff on Tableau's website, and I always direct our new users there. But for our very time poor people who can't even be bothered to follow a web link, then showing them something just really quickly shows them they don't want to read a page of A4 with a series of steps about how to export. They just want to see someone do it. I think that will become important in the future as we get more users. Another thing we're considering is a portal or like a landing page. So the way we send people to visualizations at the moment is more, we usually send them a link directly to a particular data viz. We don't stop them going off and exploring and finding other ones. In fact, I'd like to encourage that in the future, but I've never quite been happy with the sort of vanilla interface for Tableau server and exploring. And I don't know, I'll wait any future developments on that. Might change my mind, but we'll probably do something pretty basic. And I've seen some good examples online where other people have done this in Tableau. I actually built a Tableau dashboard that was a portal, which looked pretty cool to me. So something where we can just send one link to someone and have them or get IT to make that appear on their bookmarks, and then they can go there, and from that page they can get to pretty much all the content that we're building, both in Tableau or in anything else, if I'm honest. And we build a lot of stuff in Tableau, but we still use, by design, we still use SQL Server reporting services for the much more basic stuff, where we just need a list of patients, etc. And the third point there, I suppose, is around inter-application links. Sounds a bit wordy, but one example of that would be the mortality linking that I told you about before, where we're allowing users to jump from a report directly into a pertinent part of a completely different system. And in future, we might be able to do that with other systems. There's going to be so web interfaces to our umbrella administration systems are coming, and at that point, we may be able to really pick up the interest of consultants by allowing them to jump straight to relevant patient details somewhere. Also, as a quick aside, that embedding Tableau or appearing to embed Tableau, if I put it that way, into Outlook. Most of our corporate users certainly, and probably most of our clinicians use Outlook on a daily, hourly, minutely basis. So this is a real example. We haven't rolled this out. This is me testing, but of putting Tableau into Outlook. That's actually incredibly easy to do, by the way, but is quite glitchy, and I haven't done a lot of experimenting with it. So again, ask me afterwards if you want to have to do that. I've not got it to a state where I'm happy that I would want to support it, but it does kind of work. And the last point, probably the hardest point, is increasing our analytical capability, or probably should say capacity. That's both. It's not about me recruiting more people necessarily. It might be about finding some complementary tools to Tableau. Having a play with, I'll pronounce it incorrectly, but Alter YX, which looks like it might have some potential uses for us. But more of worry or interest to me, or the tougher nut to crack, I think, is around the general sort of analytical education and ability of our main customers, really. And I'm not being derogatory. They're not stupid people. These are clever people, but they're not recruited for their analytical abilities. They're currently recruited for their organizational or clinical abilities, understandably. But getting people to that level where they're certainly able to understand all sort of standard terms come out. They know their medians from their means, etc. But also that they are comfy with new ways of looking at data. So there's not a great tradition in the NHS of looking at scatter charts. I won't say these people have never seen a scatter chart before, but they're not familiar with consuming their information in certain ways, and they're going to take a little bit to get there. And we don't want to be too rigid about standardization of some of our views, but Tableau lends itself to if you want to show a relationship, scatter plot is a really obvious way to show a relationship between things. And the reason we've done a lot of scatter plots in the NHS is people don't look enough at the relationship between things. So there's a lot to do, and Tableau definitely has a big part to play in getting us there. So that's pretty much me. Any questions? I'll take them now. Thank you.